Today's video, we're going over my favorite treatments for frozen shoulder. By and large, conservative treatment for frozen shoulder is successful in up to about 90% of folks that have frozen shoulder. And generally speaking, the best treatment is going to be some sort of cortisone injection or cortisone plus physical therapy exercises. In today's video, we're going to talk about evidence-based strategies in the treatment of frozen shoulder from the American Physical Therapy Association Clinical Practice Guidelines and my favorite way to implement these treatments. First up is going to be patient education. The Clinical Practice Guideline gave patient education a grade B score in terms of how good the evidence was on patient education. So what does patient education consist of? Generally speaking, you want to educate your patient about the positive prognosis of frozen shoulder. Essentially, if we exercise these and we use cortisone, they tend to do really well. Second piece, you want to modify activities that are creating a whole bunch of pain. We still want to use the shoulder through a pain-free range of motion. We want to back off of activities where we're really reaching and aggravating the shoulder. Because we know if we overdo it with exercise or regular activities, it can actually slow down your progress over just listening to your body a bit and obeying those pain parameters. We also want to let our patients know that there's a positive benefit to cortisone injections and different types of cortisone treatments. So if you get a patient and you think they have a frozen shoulder, you probably want to send them back to the doctor to get a cortisone injection before you start your exercises. And lastly, we want to encourage stretching of the shoulder based on their level of irritability. So during your clinical examination, we really have to figure out how aggravated is this person's shoulder, then give them exercises that match that level of aggravation and make sure your patient is going home and they're not overdoing it. So the Clinical Practice Guideline did recommend a few modalities in order to neuromodulate pain. And the ones they recommended were heat as well as E-stim. So you can utilize heat at the start of the session, and you can utilize the stim afterwards if you like to kind of reduce the pain after you kind of irritated things a little bit with your manual therapies, or you can apply them both at the same time. I'm not sure if there's going to be a best way to do it, but I tend to do heat before and then stim afterwards. So stim pads, we're using 10, so it's not rocket science. Generally speaking, I'll just place electrodes right over the area that hurts. Keep in mind, these folks usually have kind of dull pain that's not really localized to one area. So you can basically put those stim pads right in the areas that kind of hurt, or more broadly around the shoulder joint, since we know the shoulder joint itself is what's creating the patient's symptoms. Just like so. Once we have it connected, we can turn it up for 10 or 15 minutes, take the heat, throw it right on the top, nice and easy. Next recommendation from the CPG was stretching. They gave this a grade B evidence. And here's the thing, what they were saying is that we don't know the exact exercises that are going to be best. We also don't know what are the best sets, reps, volumes, frequencies, so on and so forth. So when we go through all of these exercises, which these are my best guess for what works the best, I'll go over some of those sets, reps, frequencies, what you can consider with your patients over the course of time. First thing we're going to focus on are going to be the passive range of motion or active assist range of motion. These are most appropriate for folks that are highly irritable. And generally speaking, when these folks are highly irritable, we don't want to blow through pain whatsoever. And moving through a pain-free range, getting to the point where you start to feel a little bit of that pain, that wall, and then backing off of it, back and forth, right? So we can very easily do this with good old Mr. Dow, Mr. PVC. We'll start off by trying to mobilize into external rotation. Do keep in mind that external rotation is usually the most provocative, so we definitely want to do it. You just got to proceed slowly with some caution. So first, we can take Jackson's elbow, just bring it directly to his side. We give him the PVC. He's going to hold on to this. He's going to assist himself into some passive, a little active assist range of motion. Yep, going to the point where he starts to feel that wall and then backing right off of it and just going back and forth. And what a lot of patients will notice over the course of time, they just gain a little bit of range of motion, and that's what we're shooting for. But we really don't want to blow through a bunch of pain. Patients tolerating this really well, we start to bring them up into about 45 degrees of external rotation, and again, it's the same exact thing. Going to the point where they start to feel that pain and back off. Once patients start to feel better and better, we can get up even a little bit higher. So I'll take my patients up to about 90. If it's too much to be in extreme horizontal abduction, we can elevate them a little bit with a towel so they're more in the scapular plane. And from here, go ahead and perform your external rotation. Excellent, looks really good. Another good exercise, it's super easy to do, is just PVC flexion. So from here, let's have you grab this down, yep, pressing this thing overhead. And then from here, very slowly reaching overhead. Same rules apply, so in highly sensitive folks, we definitely don't want to push that range of motion. Just go to the point where it starts to kind of kick in and then back right off of it. Great job. And as people progress, next step I like to do is I like to give them a Y. So essentially, we're making the letter Y with our body, one arm at a time, and we're assisting with the opposite side hand. So go ahead, yep, and grab that palm up, very good. And from here, just going into that Y position, going to the point where you start to feel that pain and then back right off again. Yep, excellent. So a couple really good exercises you can start with, starting with the easy exercise into external rotation, up at the side, maybe starting with the flexion. And as things start to progress, we work ourselves into more abduction and later throw in that Y. If you are enjoying this video right now, I have something else I think you're really gonna love. It is an evidence-based cheat sheet on frozen shoulder. Here's the thing, staying on top of all of the medical literature that's coming out is a pain in the butt. No one wants to do it, but here's the other thing. I'm a psychopath and I love doing it. So I've created this cheat sheet to do exactly that. My promise to you is I'm gonna get you up to date on the latest literature on frozen shoulder in under 10 minutes. We go over the definition backgrounds, we go over prevalence as well as risk factors, pathoanatomy, as well as a clinical course of frozen shoulder. We talk about how to diagnose this accurately, as well as how to go through your differential diagnosis to make sure you're not diagnosing the wrong thing. We go over the best outcome measures to use with your patients, how to perform your clinical examination, subjective, objective. Then we go over the best treatments based on the irritability of your patients. And lastly, we round it up with different treatments like corticosteroids, surgery, and some of those interesting treatments you hear about like hydrodilatation, as well as suprascapular nerve blocks. So go ahead and click on the link in the description. This is 100% free. You get instant access. Like I said, I'm gonna get you up to date in under 10 minutes. I do the work so you don't have to, and can speed up your knowledge as a coach and clinician. Now, back to your video. So as your patients are starting to improve, their irritability is going down, you get that cortisone injection, they're feeling pretty good, I start to transition over to active range of motion. My favorite way to do this is going to be on a ball. So from here, we can draw a variety of different letters. So you can make the letter I, Y, T, U, and W, right? So first, we're gonna have Jackson lay back. If he needs to have his head supported, then maybe perform this on a bench so he can relax his head. If he feels okay here, then we can just perform it on the ball. So the first thing we'll do is reach up towards the ceiling here, Jackson, and then go fully overhead. Make that letter I. Very good. And just reaching towards the floor. You may pause for a second or so at the end range of motion, get a little bit of a stretch. But again, don't blow through a bunch of pain. That's really important. The second letter is gonna be a Y, which is the same exact thing, except we're a little bit wider with our hands. Yep, reaching back towards the floor. Excellent. Let's try a T next. Very good. And next, we'll go kind of tackle external rotation a little bit by using the U. So in the U, the elbows are level with the shoulder. Yep, and you're flipping your hands back to try to reach for the floor. And the last one's a W, which your elbows are a little bit close to your sides. Yep, and you're trying to flip your knuckles back down to the floor and try to touch. Excellent, good job. If we want to advance these and make these a little bit more challenging, all we need to do is add a little bit of weight. So I'm gonna give these to Jackson. Let's say his shoulder's progressing along, he's feeling a little bit better. And let's perform just a couple T's. So he can use the weight to stretch him a little bit further, gets to the end range, holds for about a second, and comes right back up again. Excellent. And if he's feeling really good, I'm gonna apply a traditional stretch, and this is really towards the end stages. So think about their shoulders are no longer painful, but they are still stiff. We can actually hold this stretch for a period of time. Let's go back into our T, and you can hold for 30 to 60 seconds, or whatever you feel is appropriate for your patients. One cue I find to be really helpful for patients with frozen shoulder is you basically set up in supine, you have the elbow, level with the shoulder, you twist the hand, thumb back, that's very important. And then from here, you take your phone, set up the fitness pain-free channel, and then as your patient does the exercise, they go down, you already got them a little bit because they can't see what's going on. You actually have them hit the like button. And on the second rep, maybe go down, you hit that subscribe button. And if you have enough time to do the reps, you can maybe leave a comment because that really helps the algorithm. So definitely do that. One of my favorite ways to work internal rotation is right here. So keep in mind, if a patient is really irritable, don't start them here. But as they start to get better and better, we still need to work on internal rotation range of motion if it's stiff. So essentially we have Jackson here sitting on the table. He has his foot up on the table, then he has his elbow on his knee. You can't really see it here, but his arm is in the scapular plane. It's not straight off into abduction, but into scaption, which tends to feel a little bit better on the shoulder. And from here, he's gonna bend his elbow and just allow your arm to go into internal rotation. Yep, he's getting a nice stretch at the very bottom, coming right back up again. If he needs a little bit more stretch, he can use his opposite hand to apply a little bit of overpressure at the very bottom. And again, at the end stages of rehab, we can hold this, or we can just add a little pressure and then back off. And if we wanna get a little bit spicy, we can add a little bit of weight, just like we do with the other letters, coming all the way down, full stretch on the bottom, right back up again. But again, I'm not giving my patients this in the early stages of rehab. This is probably a little bit too much to start with. Towards the very end stage of rehab is when we can start to incorporate more classic stretching. One of the easiest ones to do is your traditional pec stretch, right? So let's go ahead and take your elbow, make it level with the shoulder, Hand goes up right on the rig or through a door, also works really well. You can also use a corner of a room, so essentially you're facing the corner, hands are on the walls coming in. So from here, go ahead and walk through and rotate slightly. We're looking to get a little stretch. Now we can either hold this for a period of time, or if the patient is a little bit irritated, we can go to the end range and then back right off again. Can you show me a couple of those real quick, Jackson? Awesome, very good. It's also worthwhile to work multiple degrees of abduction. So let's have you go right back into that stretch here. And what we can do is we can slide the elbow down just like so, and go ahead a few stretches for me. Very good. And the last thing we can also do is you can drop the elbow all the way to your side, hands right here, and then go ahead and stretch into external rotation the same. So what I like to do is just to work multiple degrees of external rotation and pec stretch. And once your patient is starting to get better and better, you can just spend more time in whatever position is still the limitus, or has the most limitation. I don't think limitus is the right word, right? But make sure you're measuring over the course of time just to see which directions are still limited, and then you can apply the right exercise for whatever's still stiff. We can also perform a basic overhead stretch, also known as a lat stretch. So essentially you want to grab on something that doesn't move. Rig is really good. And Jackson right here is going to step back with his right side leg. You can see really easy from the side, he's going into end range flexion here. We can do a couple different things. So just like with the pec stretch, we can hold this position, or we can kind of back off the stretch and then lean back into it a little bit, back and forth, maybe holding for a second or so, getting a little stretch. I usually don't stretch people that are irritated, but if they're feeling pretty good, we can go for it, right? Towards the end stages of rehab. Next, we'll chat a little bit about joint mobilizations. The clinical practice guidelines gave joint mobilizations a grade C in terms of the evidence. So it's not great, but I still tend to use these with my patients. And we can mobilize in a multitude of directions. Do keep in mind that generally speaking, anterior mobilizations tend to be most provocative, probably because that's the portion of the capsule that's usually most involved when folks have frozen shoulder. But you probably want to make sure that you do intervene on that, because again, it's the stiffest. We have to be careful with how much we push for these folks. So someone is very, very irritable, we're using kind of maybe grade 2 mobilizations. And once folks get a little bit less painful, a little more stiff, we can focus more on those grade 3, grade 4s, even some sustained grade 4s, really trying to mobilize that capsule. One of the things we're looking for is that there's minimal pain while you're performing these exercises, and we shouldn't flare them up after the session. So if the patient feels really good during the session, next day they feel like garbage, they did a little too much, right? Next, we'll go over some of the mobilizations. We'll start with a posterior mobilization. This tends to feel better of the three compared to the anterior mobilization. So Jackson's on his back, just like so. What I like to do is to grasp the patient's hand with my armpit, so make sure you take a shower that morning. From here, I'm going to take my hand and make sure that I'm on the humeral head, right? So my hand is right here. I take this portion of my hand, goes right on the humeral head, and my force of application is going to be posterior, but also laterally. So think about the glenoid and how it faces here, it doesn't face straight out. So when I end up doing my mobilization, I want to push posteriorly, but also laterally. So here, taking up the slack, applying my mobilization, and again, how hard you push is going to depend on how irritated that patient is. In order to perform an inferior glide, very similar. So essentially, I'm going to switch. So now the patient's hand is in my opposite armpit. I'm going to take that web space in my hand, just like so. I'm going to find the scapula. I'm going to go right off of it. From here, I want to make sure I'm on the humeral head and just impart an inferior glide straight down towards the patient's toes. Next is an anterior mobilization. Again, you have to be really careful in this position. So in order to grade this, we can start our mobilization with the elbow a little bit more to the side. If you start this mobilization with the elbow real high and greater degrees of abduction, that may really kill your patient. So if it really hurts, back them down a little bit, all right? So from here, what I'm gonna do is hold on to the patient's arm. I'm gonna find the scapula. I'm gonna go along the edge of the scapula until I come off onto the deltoid. So I know if I push down in this position, I'm actually on the humeral head. And from here, my force is going to be straight anteriorly. You have to be a little bit cautious with this one because it can be provocative. And if I want to make this more intense, like I said, I can bring the elbow up higher into greater degrees of abduction. And the last thing I can do and be very cautious with this is I can take the patient, place them into some external rotation, and then mobilize right here as well. So we also have some interesting research that shows that if you add strengthening exercises to your program, that helps to improve range of motion. Now I can't tell you exactly why this is. Maybe there's some sort of pain modulation to the strengthening, but if we want to enhance our outcomes, we can add some basic strengthening. And in this study, they weren't doing power clean and jerks, right? They were doing basic exercises. So including scaption, sideline dumbbell external rotation, prone extension, and prone dumbbell rows. What I will say is that as my patients get less and less painful, I typically work with a lot of folks that are trying to get back to training in the gym, CrossFit, Olympic weightlifting, powerlifting. I will give them exercises within their pain-free range of motion as soon as they can tolerate it really well. So if someone can tolerate something like a dumbbell floor press, I'll put it right into the program. If they can tolerate something like a TRX row, put it right into the program. And as we progress over the course of time with range of motion as well as tissue irritability, we just go closer to end range. So think about starting with a dumbbell floor press, progressing to a full range of motion press, progressing to an incline press, and eventually something like a dumbbell overhead press. Clinical practice guidelines also recommends a neuromuscular re-education, which is a fancy way of saying patients are going to move weird because they had frozen shoulder. We want to make them move more normally after they're getting out of frozen shoulder, right? And in the beginning stages of rehab, when someone is really stiff and they're really painful, we might not be able to cue them out of those positions. And the reason why they're doing weird stuff is probably because they're trying to protect that joint. But as stiffness goes down, as pain goes down, we want to make sure they're moving more normally through the shoulder joint again, right? And this is gonna go for every exercise in the gym moving forward. So once your patient is at the point where they can do rowing and pressing, so on and so forth, make sure you cue them so that they move normally. But in the beginning stages of rehab, the big ones we're gonna notice this with are gonna be with elevation or just basic kind of flexion of the shoulder. So go ahead and show me one scaption rep with a lot of a shrug. So you're gonna see patients that end up moving into a lot of elevation and upward rotation of the shoulder blade because A, they used to be really stiff, right? They built a bad habit when they were stiff, or the shoulder joint was painful or still is, and they're trying to move from the shoulder blade because the shoulder joint feels like garbage, right? And as physical therapists, we're usually pretty good with this. So let's have you raise up, we'll have that shrug, and I want you to relax that shoulder down. Good, good, good. If you have a patient that has a really hard time doing this, you can bring them up passively, and they may be shrugged. You can cue them down, relax that arm, and then keep this shoulder down as the arm comes back down towards your side, right? If they're having a really tough time still, and maybe because they're still a little bit too painful, right? Maybe a little too stiff. So just keep those in mind. If you try to do this too early, you're just gonna compensate, and that's simply because of pain or because of stiffness. Next place we're likely to see a lot of compensation is with your basic rotation exercises, like a sideline external rotation. So Jackson, go ahead, pretend like you have a frozen shoulder. Show me how you would move if you had a stiff joint or a painful joint. Very good. Yep, and then back. So Jackson's really selling it here, but essentially you saw it, he's moving more through his trunk. The other thing you'll probably notice with these folks is when they go into internal rotation, they'll probably dump the shoulder blade forward. When they go in external rotation, they're gonna retract a whole lot, right? And if I do this back and forth, I'm not truly moving through the shoulder joint. I'm moving more through the shoulder blade, or like you saw before, moving through the torso. So a couple easy cues. Basically, you take the patient's shoulder where you want it to be, tell them to glue that elbow down by the side, and tell them, hey, don't move your shoulder at all right here, stay still. And then from here, raise your hand up into my hand. Excellent, and then relax. And what you might notice is they have less range of motion now. And that's because they're still a little bit painful, a little bit stiff. And what we wanna do is work through the range that feels good. Don't blow through a bunch of pain. Don't cause a whole bunch of compensation because you're trying to get a greater degree of range of motion. We're really not accomplishing what we want if we do that. I'm not saying that you should never move through your shoulder blade for the rest of your life. It's definitely not what I'm saying. Over the course of time, obviously we want normal mechanics, but early on, you're gonna notice these folks don't wanna move through the shoulder joint, so you have to help them out along the way. Hopefully you got a couple good exercise ideas for your patients that have frozen shoulder. I actually really like to use soft tissue mobility as an adjunct treatment along with my modalities like E-stim and heat early on in rehab. If you wanna learn how to perform the exact manual therapy techniques, soft tissue strategies I like, folks have frozen shoulder, I'm gonna leave a link up in the corner. Go ahead and click on that link and I'll see you in that video.